you can find a study, you said, okay, it's red, and you can find a study, you say, okay, it's yellow. And
Right.
what I have to do for my patients? And it's really difficult. I believe it's very difficult to know exactly more in occlusion, because occlusion, you have one school and they said, okay, we have a good result, and you have another school and they said, okay, we have good results, and another one and you have good results.
Correct.
And so what? And you try in one way, it's good for some patient, but not for all the patients. And so another, and it's the same and the same and the same. This is why I find it very interesting to learn from all the school and to keep in your mind, okay, this technique should be good for this patient, but this one may be for this patient.
Yeah, so yes, we collect same information, but we all use it in different directions.
Yeah.
So for you, it's big part of facial aesthetics. So in which time, and maybe this cross-link with some of the questions at the end, but I want to get from you, for the audience, the people that doesn't know you, the entire picture. So from which part is you start, how you describe facial aesthetics into this involvement of the process? Is this part of just the aesthetic patients that you have, or eventually you have patients that they going through you for pain?
Most of my patients are, I have to say it's 50-50. I have to say I prefer to treat patients without symptom. It's easier. It's faster.
I think we all do.
Faster. But in my practice, 50% is for aesthetic and rehab with no symptom, and 50% is for symptom. And for symptom, it's not for aesthetic, it's just for symptom. And so for symptom, I find it's very, very difficult. Too many factors and physiologic factors with a lot of things like posture and sleep apnea and position of the tongue, a lot of things, physical things, but sometimes I think also a psychological thing. Sometimes I find some patients, I believe they exist because of the symptom. And sometimes I'm not sure they want to be treated, because if you treat them, the symptoms disappear. And because some of the patients exist with the symptom, they could imagine they don't exist anymore if the symptoms disappear.
It becomes part of their identity. Yes, I think that's a very deep rabbit hole that we can get into another time. Absolutely true, because we know that long-term pain can definitely have a lot of limbic system connection, and once that happens, really, it's very difficult to kind of separate those patients from that, and it will bring to us that there is whole set of other professionals that need to help us there.
Exactly.
But let's go ahead.
So then so technically you're saying you have two kind of patients, 50% cosmetics, 50% pain patient. Is any point of transition of those pain patients to an aesthetic phase? And again, this will interact with another questions, or you doing ortho? How you doing that transition part of it?
The transition between occlusion?
No, between pain and then eventually those patients come back to be just aesthetics?
When the patient comes for pain, I focus only on pain at the beginning. Just answer the patient, it's pain, focus on pain. Because the mind of the patient is absolutely not open for aesthetic. Even if the smile is horrible, it's not a problem for them, it's just pain. So what I do is, okay, they come for pain, I have to treat the pain. And so I treat only the function. I try most of the time with a splint. I don't like the splint, but my patient come from very far. So if I place a mock-up and the patient come back home, and you have a problem with the mock-up, it's difficult to remove the mock-up and the patient has to come back to the office, and sometimes it's 1 or 2 hours with plane. Sometimes it's 6 hours with cars. Wow. So it's very far. So I prefer for this patient to place the splint just in case. So we start with the splint or the mock-up, and we adjust. I work when the patient has pain. I work with my chiropractor, and I send to the chiropractor before I record the new position of the jaw. And after that, I check, of course, the muscles, TMG. I check the place of the tongue. I check the eyes. And also I can work with a podiatrist, how the feet touch the floor.
Okay.
And the last one is also the sleep apnea. I ask the patient if he has a problem with that or not, and to have a test if he don't know.
Now, before we get into the questions, I want to get to learn a little bit about what I'm seeing in your last lectures. I'm a big fan of what you do, and I've been watching lectures, and since I've been going to France and trying to kind of learn a little bit of French, so I just some of your, it's difficult. I know the stress that you're right now because a foreign language is difficult. Look at me, I'm still don't speak English, and I've been 20 years in America, right? So imagine to me trying to learn French. Anyways, you saw a lecture that you did for an organization in France. I don't remember the name, but really beautiful. And then part of what I'm seeing in common is now you combining some concept of the strategies of Dr. Coy's. We're going to have also Dr. Lucas Laxman for Poland, that also is one of the Dr. Coy's advocates. But since we want to try to find what we have ground in common, I want to find how you find in common in those two process of thinking, and explain this a little bit. We honestly really want to know, because definitely if it's something that is gonna improve maybe the
simplify.
Yeah.
Correct. That's what we're looking for.
So whatever you want to tell us, how was that thinking process from you to become a neuromuscular, and then in some point say, I'm gonna get this information for here and I'm gonna put it together, and boom, this is speeding me this time, and I'm cutting these corners here, but I'm getting the same mindset. So tell us about that.
So it was in 2003, I bought my TENS at K7, and I record all my patients like this. And in 2009, I found my training center, GAT Center, and I start to teach how to record the bites with the TENS and the K7. And I had a problem because everybody bought the TENS, but maybe 30% bought the K7 because of the price. You know
yeah,
that.
economy of countries, yes.
And to record a bite only with the TENS is not so easy. And I love the TENS. it's an amazing reprogrammer. But after that, to record the bites, it was difficult. It's easy when you have a K7 because you can see. And I met Florine Coffard in 2015, and we worked together and we treat patients together. And
I'm sorry, who is that? Can you say the name?
Florin Kofar is from Romania, a great high-top cosmetic dentist.
Okay.
He's an international speaker, and he's one of the biggest developers of optimization and intelligence, artificial intelligence in planification of cases. So
okay.
He's a really top leader in high-end aesthetics and digital.
So we treated patient together, and so he did the aesthetic part with his concept, and I treat the function with my 10CK7. And in maybe 1 year later, he sent me a message. He said, "Cyril, look at this," and this was the cois, and you have to try this cois with the TENS. And this is how I mix the TENS and the cois. So I use the cois just to stabilize my jaw. So I record with the TENS and with the physiology of the patient. So without touching the patient, just the patient give me the position. I don't push the position. I don't manipulate the patient. And with the cois, it's now very easy because the patient has just to close gently, just touch the cois, and it's done. And with this system, you can adjust with the cois the verticality. So just the per verticality, it's done with the cois, and all the other dimension, sagittally, transversally, and the pitch roll, it's done with the TENS. And so this is how I mixed and the TENS and the cois.
Yeah.
And the guy is Florin Coffard at the beginning.
That's good. So I have to accept that I do some of those things like that, but it's sensitive in my hand. So this is the situations that I get exposed when I try that. One is definitely it's important to keep the patient in a good position, because the benefit that we have with the TENS that we have this pulsation, right? But then if you have the patient in the dental chair, that pulse is gonna go back. So to me, it's sensitive to posture. Also to that position of the little ramp that is the device where we're gonna stop. And part of my foundation, it comes for Pedro Planas, an orthopedic from Spain that in the 70s. And he developed something that is called the pistas de planas, or the landing tracks. And he always was designing everything based in camper plane. And he make all the studies in camper plane. And then when I start playing with this device, I will say in the way that another people I'm seeing they using it, they try to use like the inclination of the ramp to allow the condyle to sit back. So they put the thing in a state to have it flat. They will try to make this inclination like the same when the patient bite down in the Lucia jig, that it will close the joint, the pack, that is valid, but also it will influence a distalization of the mandible. So in the first try, because you know that I'm planning a lot of cases through digital dentistry that allow with digital software, that allow that you can see the joints and everything together. So my first attempt, I start playing with that inclination, right? And then I say, yeah, if that inclination became too steep, even that the patient is tensing in there, is still creating a vector or force to distalize the mandible. So that was my impression. Then in my second attempt, I redesigned the jig, and then I put it more flat. And I say, okay, the idea is this needs to be flat. Now, what I found difficult is that we found a huge population of patients that the garage is smaller than the car. So the maxilla is behind. So part of the complications in neuromuscular dentistry I think it's because not many people is controlling the joints and they get too much freedom just by the muscles by itself. And then you get eventually mandibles that they go a little too forward. And then we will have a competence between the upper incisals and the lower incisals. So I found in those cases that was kind of almost impossible to use the jig, because if you were trying to preserve a vertical dimension into the aesthetic zone, that mandible, because a deficit of growth or the position was wrong or the crowding or whatever, it will create this interference. So I thought, okay, this can be benefit to coach a bite for somebody to guide it and say, okay, we have the patient restored in phase 1. The patient is out of symptoms, but I need this vertical dimension based in this aesthetic zone. And if I already analyze the patient into the spleen, let's say, that I know where it's going to be the AP of the mandible, I will say, okay, this patient will apply that I can put here and stop my bite here. But I don't know for you, because this is honestly, now that I've been teaching courses in France as well, the faces are so different. I mean, it's incredible how you find different morphological changes, even when we were in Japan, that they really collapse. So I found, like here in America, we have a tendency that, yes, we have maybe bigger discrepancy between the maxilla and the mandible. So how you do this, or you are still using this idea or this concept when you have cases that you see that that mandible goes forward more than you were expecting for the aesthetics?
Oh, um, I now I use more ortho than before, for sure. Before, maybe I did 1 or 2 cases a year with the ortho, and the rest just with prosthetics. Now I love to do ortho. It's ortho just most of the time. It's just to prepare my restorative prosthetics. Yeah. And so sometimes I realize ortho to place only the upper teeth at the right position, so to expand the maxilla. And after I record the place of the jaw, of the mandible. This is one point. The other point is I have no patient who want surgery, orthodontic surgery. Maybe if I have a patient with pain, I place the splint, and after this the pain disappears. Maybe the patient at this moment will be okay with the surgery because he knows that the pain has disappeared. But at the beginning, when you explain, okay, maybe we need surgery to treat your case, most of the time the patient say, no, I don't want surgery. Try without surgery. And so I have many cases which are compromised. Just maybe as you show, maybe the patient have to be like this for her body, but because we need compromise, I record the patient like this, and we try with the patient, and it's correct. If the pain disappeared, we said, okay.
Because the detorquing can be in many cases enough. Remember, this is what we were seeing. Look at Dr. Ben that he was talking, and in his principle, even that he applies neuromuscular dentistry, he started with this technique to remove interferences, and then he removed the pain. So I consider that maybe in this approach, maybe, yes, can be one dimension that can be a little restricted, but I think you have the other dimension to try to catch up. and also I think can be into that aesthetic zone. Now, let's say about, so you following these cases and you taking data, EMGs, what you observe in these cases that you restore like that, like which compromises for the neuromuscular point of view, what the that we manage, you see in those scans when you get the spaces that you work with this combination.
Can you tell me again,
Yeah.
Javier?
In these cases that you do in combination, that eventually you know that the mandible is going to be here, but you say, okay, it's going to be a compromised case, I'm going to do it a little behind. You follow up in those cases and you make eventually more EMGs, so eventually you're tracking. What you observe on those cases?
Most of the time, if the symptom disappears, many years after, we can some symptoms can appear again, comes back. This is one thing. Another thing is the occlusion, the position of the teeth are not so stable than if you place the patient exactly on the right position. What I can find is, I think I have 2 or 3 cases like this. We can, after 2 or 3, maybe 5 years, we can create some diastema between incisors. It's like, maybe it's like maybe the tongue is not at the right place. Yeah. Maybe the mandible is too retrude, and the tongue needs more places. And if the tongue needs more places, she push the teeth, and the teeth move, and that creates some diastema between the teeth. I have some cases like this. And other thing is, and sometimes I can have some clicking. If you have some click at the beginning, sometimes you have click, and when you tense the patient and place the jaw, the click disappear. Okay, perfect. But if you place the jaw a little bit too much retrude because of compromise, the click disappeared, but maybe 2 or 3 years after, the click appeared again. This is the kind of thing I can see.
That was a great description. Yeah.
Yes.
With 30 minutes, so now we can start with the questions.
The questionnaires, yeah. All right, so Cyril, having explained all these things to us at this point, and you have answered it to a certain degree, but if you can just put that together now, what is occlusion to you today? What is occlusion to you, and who were your main influences?
Occlusion for me, first, I don't really like occlusion, because for me at the university, occlusion was only static. For me, occlusion is just clack, 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 it's occlusion. I like the term of function. Function is something dynamic. And so function is 2 things. The first thing of function is the place of the jaw in the space. Why is the jaw? And when we find the place of the jaw, the second part of function is contact between the teeth. And contact between the teeth is when you bite in static, and also mastication. Mastication is, for me today, mastication is the most important.
Of course, you have Professor Legal
Yes,
here to you.
and for sure, Legal is one of the dentists in function the most important in my life, for sure. I
Dr.
was in
Legal.
postgraduate in occlusion in 2000, and Marcel Legal wrote his book at this period, and it changed completely my vision of occlusion, because it's not Marcel Legal worked on mastication, but not only on mastication. He worked also in how to find position of the jaw, and he worked with deglutition and a jig and relaxation of the muscles, and he worked about it also. So it's a very important guy for the function.
Beautiful. I
Fantastic.
didn't know that you have influence for him. That's awesome. We're gonna have actually another doctor from France, Emilio Leber, and he also is gonna. He's purely focused in chewing cycles with Dr. Lega. And
let me say you something, because it's very funny. So I was in LVI. It was in 2005. So I was in LVI, and in LVI you play the tense, you know that, and you record your bites, and you feel how your bite has to be in neuromuscular dentistry. And back to France, it was my level maybe 2 or 3. Back to France, and I went to Marcel Legal office. And I had a course with Marcel Legal to learn about mastication. And so I think we were maybe five dentists in the office of Marcel Legal, and he gave 2 days courses, and we had a lot of hands-on, and one hands-on was, okay, I'm the patient, and Marcel Legal was the dentist, and he created a jig on my teeth, and he relaxed me, and he plays a cotton roll, and after this, say, okay, place your tongue like this, and now swallow, and do you feel, yes, this is the position. You know what? It was exactly the same position that neuromuscular dentistry.
I can tell you, I have the same story with Francesca.
Yeah.
Francesca was taking my course in Dijon, and I used it as a patient, and the same. She take the bites in the way that she take it with the cotton rolls walking. We get the 2 bite registrations, and that thing was almost identical. I can tell you, something that can be balanced by occlusion. But this is the beauty of this. Honestly, I think the intentions that we have is, as far as you have all the aspects covered, that you can know that occlusion is not just the teeth together, that the neck has a huge influence, that the airway has an influence, that the tongue has an influence. Doesn't matter how you do it or you get there. And wherever it works for you or working your hands, not everything works for everybody's hands.
Yes.
And then, yes, we all human beings. And then if we can get this, I will say, I think the beauty of this is because I know now that this is over, what I need to try to focus to start digging more, you know? This is beauty. This is not an end.
There's a whole lot of physiology in all. I mean, this has been the real common thread among everybody that we have talked to so far. And it's funny how everybody thinks they're so different, but they're all talking about the same physiologic factors. They're all talking about function, because nothing without movement and function makes any sense. We are not a static entity. We're moving. We're, you know, at all times there's movement. So let's go to question number 2, which is which are the factors that you consider prior to stabilization? What are things that you're looking at?
The comfort of the patient and the symptom of the patient. It's something really important, how the patient feel, because if I record something if I record all my patients, everybody has a problem of occlusion of function. Okay, it's like if you go to the chiropractor or osteopath, you have a problem with your feet, with your leg, with everything. But nature is beautiful, and you can live with that, and you can live very well with that. So one thing is the comfort of the patient, and the other thing is if I have to treat the patient, if I have to increase vertical dimension, to change the function, I don't want to manipulate the patient. I want that the patient gives me the position. So I take care of muscles. This is something really important because I think everybody is agree with that. Muscles is a part of the function with the most power. Muscles can destroy everything. Muscles can destroy your TMG, muscles can destroy your teeth. So take care of the muscles. This is something important. And also take care of TMG, because you cannot place the joint everywhere. The joint has to be placed on an area. And after this, when you have the muscles at the joint at the right place, after this, you can place your teeth, your restoration.
Perfect. So if I heard you correctly, you do look at the structure from far, in other words, the posture, then you look at muscles and the joint space.
Yes, exactly. And if the patient has symptom, I work with my chiropractor directly. So if the patient has no symptom, okay, I do my treatment without my chiropractor. And when I test my new occlusion, if I have problem with the patient with some pain, I send the patient to the chiropractor. But if the patient has symptom at the beginning, I send to the chiropractor, and after I record the position of the jaw.
Perfect.
Right.
Do you have something to add there, Javier, or should I go to question number 3?
Yeah, question number, he covered a little bit of a few other questions, but it's okay. That's
okay,
fine.
Yeah, I know, we're crossing over.
Yeah.
Cyril, can you tell us what diagnostic records do you take prior to starting your cases?
I can do CBCT.
Okay.
Electromyography, and after I use also an amazing machine. I found this machine amazing, a Mojo, because with the Mojo I can record.
I'm not familiar with that. Can you tell me what that is?
What is a Mojo? The Mojo is a machine. It's like a imagine you have some captor in your mouth, in your teeth. You have a captor, and in front of you you have a camera. And when you move, and in fact, the camera records the movement of your jaw.
Oh, fantastic!
Yes, it's fantastic. I will show you the first.
It's something a lecture. Yeah, it's something like I've been showing in the videos that you can see the CBCT in real time. It's an amazing company developed in France. They use different optics. So like in SciCat, we utilize.
So it's an optical jaw tracker.
It's an optical jaw tracker that allows to see the movement in real time. Really, I mean, this is the newest technology we have. So yeah, great.
Yes. And,
beautiful.
And when you record something, you can record the cycle of mastication. And with this record, you can send this record to your lab, and your lab can create your splint or your mock-up with the cycle of mastication of the patient.
Oh, beautiful.
So nowadays we can work not with the...
So that information can be superimposed on your CBCT.
Completely.
And then they can, and your CBCT can have also the scan of the teeth that they can.
exactly.
Makes sense. Fantastic.
Yeah,
Excellent.
full data integration, really amazing.
Excellent.
Good.
All right, so I think that kind of like also answers our which instrumentations do you use, and also question number 5 is whether you use interdisciplinary, and you said that already, that with your symptomatic patients you work with a chiropractor.
Yeah, and also you can add orthoptist, sleep apnea doctor,
Okay.
speech therapist. It's really important.
What is more popular in France, chiropractors or physical therapists? Because every country change, you know, some people, I found this when I'm traveling, that is a lot of chiropractors that they also do physical therapy and backwards. It's like a no big differentiation in many places. How it works in France?
Physiotherapist is something very old in France, and it's yes, there are yes, and osteopaths appeared maybe 20 years ago, so not so long. In chiropractor, it's very rare, and I like to work with my chiropractor because this guy is amazing. And when I met him and I talked with him, the first thing he told me, it's you have to check C1 and C2 because it could be a problem with occlusion. Occlusion could be a problem for C1, C2, but C1, C2 could be a problem for occlusion. And he was the first guy who explained that to me. And so I started to work with him. And this is why I start with a chiropractor, but chiropractor is not something to develop it in France.
Yeah, you
Definitely.
guys in France has amazing brains. You have also in Marseille, I think you have Dr. Precop, the posturologist.
Marseille,
And I found now with the students in France is, I mean, it's beautiful because maybe they don't know much about how we do occlusion in the physiological way, but they really know posture. They have amazing foundation that I think we wish we have more influence in the States about posturology that is more popular.
Seems like they're getting to the same place.
Yeah, it's getting bigger. As a fact, we're going to have also Dr. Gustavo Bernaza from Argentina, that also he's a prosthodontics, but he's been utilized in posturology. So I think the way life is going is also all this holistic physiological approach that we will be part of the question that we will have to Cyril at some point.
Right. So let's move on because we're getting the last 10 minutes of our time. You know, you have said this a little bit, but I want you to kind of, Cyril, now put it in a step 1, 2, 3, 4. Can you give us the sequence of treatment? For instance, for a pain patient that's going to become possibly a full mouth case for you later. Can you give us the sequence of treatment for that patient?
Yeah. The sequence is first interview with the patient to explain the objective of the treatment, to be very clear with the patient. What can he expect and what can I do? Then with a symptomatic patient, he goes to chiropractor, have manipulation with the chiropractors, back to the office. He's not so far, but he's not in the same office, back to the office the same day. If it's possible, just after, I play the tense and I record the new bite.
Right.
I create the splint and I play the splint, start the equilibration with the tense, and I ask the patient to back to the chiropractor. And in my process, I have between 3 and 5 equilibration. And each time I ask the patient to go to the chiropractor and just after come to the office and equilibrate the splint. when it's stable, when the chiropractor say, okay, now it's stable, we can do the final restoration.
How long do you normally keep them in that orthosis for to make sure they're stable and
For symptomatic patients, 3 months, sometimes 6 months, and some patients have 1 year.
Okay, so it depends per case and when you feel like they have stabilized. Okay, so fantastic. Question number 7. Now, you've seen this patient, and this is going to turn into a full mouth as we spoke. When do you enter the facial aesthetic consideration into this? Was it at the first appointment, or now it's going to be a consideration now?
If the patient is asymptomatic, aesthetic first. Plan aesthetic, it's like a box. For me, the maxillary is like this. I plan aesthetic. After it's easy to place the joint inside.
Yeah, but no, that's a aesthetic case and asymptomatic patient. We're talking about this same patient that came to you, and it was symptomatic, and you know you were going to stabilize them.
Yes. So first I stabilize. So don't care about aesthetic. It's not the problem. The problem is stabilize.
I see.
Now when it's stabilized, I record the occlusion at this part, and I analyze the aesthetic, and I see if I can do aesthetic with this position. So if I can do aesthetic with this position only with prosthetics, or if I need ortho, or if I need surgery.
So your aesthetic consideration comes after you make the patient asymptomatic.
Yes, it's really a problem of communication. If I start to communicate about aesthetic and the patient has pain and asks to me to treat the pain, it don't care about aesthetic.
Yeah, that's.
Does that answer you, Javier?
Yeah, definitely. Okay, which question
Fantastic.
we are?
We're going to be on question number 8, and this is a little bit. I don't know, Cyril. Do you do any surgeries?
Implant, yeah.
Okay. So I'm assuming that are you familiar with the growth factors and biological factors for healing?
Yes.
PRF, IPRF.
Yes. I use BTI.
BTI, good.
Yes,
I use that.
Yeah, I use BTI, but only for surgery. I never tried BTI for joint. I know Anuita do that because I don't know if you know, but Anuita.
Yes, I studied with him also. I got into it. That was my entry.
Okay, and so I know he treats a lot of joint with product.
There is a big difference though. So the consensus that we have gotten, that everybody agrees that this, whether it is PRGF like BTI system, or if it's IPRF, that this stuff is doing good. The main thing is that when do you administer? Now, the consensus has been first stabilizing the bite and taking the compression out of the joint, and then introduce the factors for healing. What do you think is the proper sequence?
I don't have any experience, so it's difficult. If I have to think just about the sequence, I think I will place the jaw and place the joint correctly, and after this, I place my factor.
Yeah.
But I'm not sure.
Correct. I think
that's the common thinking process, and then that's what we're gonna have is a special guest that is Alejandro Martinez, maxillofacial surgeon, that he's gonna tell us everything about the way that he's doing it, how the way that he stopped doing maxillofacial joint surgeries to focus in something more conservative or something like that. So we're really anxious to have that. So that's beautiful. But what we're trying to get into that question is, since we think that, you know, with a restorative adhesion of and a restoration, we can change the wear and tear of that tooth, how we can use something to make that condyle to reshape. So I think for physiological occlusion, this is a pretty nice approach. So I think everybody is excited to hear how this is the process or how they can involve it into the workflows. So I'm really, really, really excited to know about that.
Fantastic. Let's go. We're in the last 2 minutes. I think we have to go a little bit over. Cyril, do you notice or do you take notice of postural changes after your treatment? Are they expected, unexpected, good, bad, positive, negative? What do you see?
Everything, good and bad.
Well, that's a good, honest answer.
I just tell you a bad, because good, everything has good, and just bad. It was one of my patients with no symptom, a class 2-2, okay, with a supraocclusion, and with a old filling and old crowns, and he want to remove everything and rehab his mouth. So need the full mouth rehabilitations with no problem with that. And so I said, okay, we have to increase vertical dimension and remove the crown, place overlay, ceramic, blah, 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 beautiful. And so I started with increases my vertical dimension, and I increased like, I don't remember, but maybe 6-7 millimeters. So I increase it.
Significant. Yep.
And I place the mock-up. And after 2 weeks, the patient arrived for equilibration. And he told me, you know, doctor, I have some pain on my neck. Mm-hmm. And on my shoulder, it's difficult to move my shoulder. And I have some paresthesia in the finger. And so because I know it could be occlusion, I say, yes, okay, we have to equilibrate maybe. So I equilibrate. And 1 week after, for another equilibration, the patient arrived completely blocked like this.
Oh, wow.
Wow.
And I say, okay, it's difficult. He said, yes, it's difficult. I cannot sleep anymore. And I go to the physiotherapist and make me a massage. And yes. And I say, okay, you know what? I want to remove everything and I want to place your old vertical dimension. And so I explain, okay, maybe it's occlusion, maybe it's too high, and I explain everything. Okay, yes, okay, if you want. So I remove everything. I place the old vertical dimension, and in 2 days, everything disappeared.
Wow, interesting. So, in that time, you were working with your chiropractor in the interconsult?
No, because it was in my process, was no symptom. So yes, it's a class 2-2, okay, but it's no symptom. So I say, okay, I can increase, but for this patient, it was a big mistake. And so maybe I could stay my occlusion like this, like with increasing the vertical dimension and set it to my chiropractor. But also what I think with age, it's when you have a class 2-2, this patient was a class 2-2 and he was 65 years old with a class 2-2. So his body is like a class 2-2. So it's not a good idea to change a part of the body of the patient to have a better normality, like a class 2-1. If its body is class 2-2, its condyle is class 2-2. And so what I want for my treatment is to integrate my treatment in the body of the patient. So when the patient has no symptom, again, I try just to integrate my treatment, and I try to change almost nothing. Because if you change something in a patient we live with that, with the class 2-2 for many years, it could be a problem. And it was an example. So it's
There's a lot of engramming in that body, especially a 65-year-old, that unless you break it up before by a physical therapist, that's really, at least in our experience, you cannot jump that. There's going to be subluxations there that are not going to just resolve because you put the jaw in the right place.
Exactly. Yeah, and as Roccabaro say, for every part of the body that has restrictions, it's just certain amount that you can recuperate. So I think those class 2 patients, for all of us, I think we know that they're more difficult patients because they definitely have the posture, the airway, everything thrown off. And then I think this was a great experience, and thank you for being so honest. And because that's where we learn for the experience that those cases is that definitely that they need an interdisciplinary treatment, because this is like a domino effect. Many people doesn't know where to start, but in a condition like that, it's a clear compensation of the system that when you were changing just that little piece, everything started becoming sensitive and symptoms coming back. But that's a really, really, really great story. And he made to appreciate the value of interdisciplinary treatment. That's beautiful. Okay, awesome.
All right, next question. Let's move on. Next question. We have two more. We have this is more of a theoretical and philosophical question. Do you think that we will ever have this kind of approach to teaching occlusion in our schools?
Yes. Yes. I think we have to teach occlusion in a simple way. Because occlusion, when I was in university, occlusion was something very complex with programming the articulator and a lot of things. And I think we have to simplify function, one thing, and the other thing, we have to think that the pain, even if the pain are in the muscle space, even the pain are in the jaw, it's not necessary because of the teeth. Maybe it could be the problem could be in another part of the body. So we have to simplify occlusion function, and we have to think we are not alone. We are just a part of the body, and we have to treat our patient with
more as a whole unit.
Yes.
Awesome.
That's now the last question is more of a question we have put in there for the sake of a standardization. Just thinking about the joint itself and the events that are happening in the joint. What do you think? We're talking about the rotation, translation events that are happening. In your mind, what do you think is happening in there? Is the rotation then translation correct, or is it a simultaneous effect? Or when you're thinking about that, I want you to think about something else. In your ideal position, when you're finishing your case, where is that head of condyle in that jaw joint?
I don't believe in rotation. I don't believe in translation. I believe the mandible and the jaw as like a plane. I record a lot of jaw position, And what, and I'm this kind of case. My mouse is this kind of case. I record the jaw is at the jaw move like this. So this is incisors, and it move
Yeah.
like this. And this movement, so I have the same contact on the anterior, and I create place just on the posterior. And this movement is not rotation, is not translation. And sometimes when I look at the patient in frontal, you have this kind of inclination. So you create more place on the left than the right. So it's not rotation. So I don't believe in rotation and translation. I believe that the jaw is in the space and the muscle just keep the jaw at this place. And if you relax the muscles, you can move the jaw as you want. As you want in 0.2 millimeters or 0.5 millimeters. It's not 5 millimeters, but you can move the jaw as you want. It's not just rotation and translation.
So it's like a swing, like a columpio, like a swing for kids. Wherever it is gonna be bounced.
Yeah.
Thank you. Fantastic. We're officially done with the questions, Javier.
Yeah, we pick his brain. Honestly, thank you so much, Cyril, for breaking this bridge of connection between philosophies, what is possible. I like pretty much the way that you think without dogmas in any way, in any favoritism at all.
Yeah.
But I think this is what it shows the reality of how occlusion need to be treated. I think it's important to have information because if you have the information, you can control the way that you work. But I consider that it's too many people that they don't even have information, and that's why they don't even want to learn more. It's not because they decide that based on the information they wanna narrow it down as you do amazingly. But the reason that we have this program together is to show the entire people how we are working different with different techniques, different modalities, getting different information, but also with the understanding of what is human physiology. That is the main point. If we, after this meeting, we get the people to understand that occlusion is a combination of multiple events, that is not just that quick question that before, like tick together, I think we will win a huge battle. We want to apologize for some of the people. The connection went down, so we have part of the lecture in two parts. But also remember, all the videos will be edited and put it back in my channel, Dr. Javier Vasquez, in YouTube, also as Hamid at Complete Health Group. And you're gonna have access to come back, review this, share with people. This is only to help to spread the concept of open mind thinking.
So much invaluable information in here. I hope people really take advantage of it and see the work from somebody that's really has a lot of good critical thinking, questioning, and moving the goalposts based on the cases they see. There is no one cookbook, step for all these cases. We need to learn to be good diagnosticians, and that's what I heard, and that's what I learned from you, Cyril. That I love the way how you're changing your seems like your dance steps depending on each case, and that's what a great physician does. You have learned a lot of different techniques, and you apply them as you see fit for those patients.
Thank you.
So we have a few questions before we finish. They were in the other live, not in this one. So let me try to reach them. Let me try to go back to the previous live. So since we already passed, doesn't matter just to answer these questions. Oh my God, what is my other life? I'm checking in my phone right now. Hold on a second. This is not this one. This is the one that I'm looking here. Okay, here we go. Here are the questions. More comments. Okay, doctor. Okay, we'll say. Um, so Matthew Dudon, I don't even know how to pronounce the names. He say, "Hello, function, design, body, and face." Function. I think he's telling us the order. He say, function, design, body, and face. Teeth and gum design, only the smile. Okay, thank you for the opinion. This we were looking more for questions. Somebody's asking about the book of Marcel Legal. Um, just as a quick reference, I put it in my website because I know people is asking for it. My website just direct to the page of Professor Legal where the book is, and it's translated in English for the ones that speak English. So you go to my page www.javiervasquez.com into the segment that say biofunctional dynamics is something that is say important information to read. I have a few articles that I've been trying to link for ICMO, for the International College. I put this one for Legal. And other articles in sense of human integration that I have in there. So I have an entire article, a title that is called Canine Guides, Myth or Reality. If you click in there, you're gonna go directly to Dr. Legal page. So for those that are asking where we can find the article or the book is there. Then we have
And please, still, you can still write your questions. We will have a system to collect these and try to get answers for you all.
so Emilio comment with us and he say Marcel and Jean Francois Lauret. Um, and that's good because I know you guys has amazing brains over there. So I love you. I love this thinking. Question here say process and checkup of the follow-up of your patients in the future. Cyril, that's a question, but I think pretty much I think you explained that. But just let's have the courtesy to tell the people. So the question again is like I think they asking, what is the process and checkup of the follow-up for your patients for the future?
The follow-up of the patient is treated.
Yeah,
Correct.
Yeah. For the patient with symptom at the beginning, I see the patient every 6 months, and I check occlusion, mastication. I check the muscles. I talk a lot with a patient about their feeling, and probably with the future with digital, I will make digital impression every year probably, and maybe I will record with the Mojo every year, just to have files, and maybe one day we could superpose every files, every impression, every movement to see if something changed or not. Because what I think, because we saw that with implant, when we do a full mouth rehabilitation on implant on an old edontellos patient, at the beginning the patient don't want to chew on the prosthetics because they pay a lot, so they don't want to damage or destroy the prosthetics, and also because the muscles are not so strong, because before they didn't have any teeth or removable teeth, so the muscles are very not strong, and so they start to chew, and it's like sports. At the beginning you are not so strong, But with training, you become stronger. And so the cycle of mastication change. And at the beginning, that should like this. And with time, that start to choose like this. And your equilibration has to change. So this is for implant, and we know that on implants. But for the patient with symptom, I think it's the same. At the beginning, because of the pain, that should very gentle, because they know pain and they don't.
Nociception, correct.
Yes. But with time, if the pain disappears, if they become more confident with the prosthetics and with the pain, they will chew harder, with a large cycle of mastication, and we could have a problem later.
Correct.
So we have to check with time the cycle of mastication.
It's a very good. That's a very good point. With implants, we also know there is a couple of different things. You know, of course, we all know we have the osseointegration, but the osteoperception doesn't start until about a year and a half after they have, and that's another thing that changes the cycle. That's true.
That's awesome.
Thank you so much.
So thank you so much, Cyril, one more time for this amazing time talking with you together. Definitely next time that I'm gonna go France, we need to meet in person again and got some wine and some beers, and maybe I will make you smoke a cigar, and then we will have some fun. All right, guys.
Fantastic.
So we
Thank
get
you so
into
much,
it.
Cyril. Very good to meet you.
Thank you for the interview, and thank you for everything. It was a great time.
Thank you so much. So then we been ready for the 6 p.m. Interview. So we're gonna have Dr. Mariana Evans. She's originally from Croatia, but she lives here in the States. She's orthodontics and periodontics. And she's gonna talk about something that I found it really fascinating. I have the opportunity to be lecturing with her at the Academy of Equilibration Society. And when I get to the room, she already started. And the only thing that I seen on a CCVCT is like 10 millimeters of space in the entire raphe. And I say, what the hell is this? And then I see it and I start seeing how amazing is this approach that I think apply for all these patients with a sleep apnea, with collapsed arches. So she's gonna tell us a little bit about rapid expansion in adults, using mini implants. We don't using, or we not abusing the periodontal ligament. That is one of the rejections that many people has.